Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters. I'm Dr. Arti Thangudu, endocrinologist, founder of Complete Medicine and Hey Healthy, and someone who has been thinking about today's topic for almost a decade. This episode is about diabetes distress, what it is, why it is not the same as depression, why we miss it clinically, and why the people who live with diabetes and those who love someone with diabetes need to understand it as much as the clinicians do. I want to start with something personal. When I was a fellow at UPMC, I did a quality improvement project looking at CGM access and adoption and its effect on diabetes distress scores in people with type 1 diabetes. What we found was that when people got access to CGM, their distress scores improved. This wasn't a large study by any means, and it was more a signal than hard evidence, but signals like this can be powerful. My work in my early career has stayed with me in the way I care for patients, because it supported something I already felt intuitively. That the burden of not knowing, the constant guessing, the fear, the vigilance without information is itself a source of profound suffering. And that when we give people better tools, we don't just improve their A1C, we improve their lives. I get that too much information has its own stressors and can be overwhelming in itself, but when I ask my patients if they'd rather lose their CGM or their pump, they always say they can live without the pump, but the CGM has to stay. My fellowship project was the beginning of a thread I have been pulling on for 10 years. Today, I want to share what I've learned from my patients. Let me start with precision because this term gets used loosely and it matters. Diabetes distress is not a psychiatric diagnosis. It is not clinical depression. Diabetes distress is a natural emotional response to the demanding self-management of diabetes, including frustration with treatment requirements, concern about potential complications, a sense of defeat or hopelessness about diabetes management, and reduced motivation for self-care. It is the direct, logical, exhausting consequence of what type 1 diabetes actually demands of a person every single day. Type 1 diabetes demands more decision-making than one person should have to handle. Diabetes distress is extraordinarily common. Diabetes distress is estimated to affect approximately 1/3 of all people living with diabetes. I suspect it is closer to 100% if we look at people with type 1 only. Yet, it remains dramatically under-recognized and undertreated in clinical practice because we are not spending the time to talk about it. We are not proactively bringing it up, because the system gives us less than 7 minutes with the patient once every few months. That's not enough for something as personal and complex as diabetes distress. Here's why the distinction from depression matters. Diabetes distress and depression are correlated and overlapping constructs, but they are not interchangeable. Someone experiencing diabetes distress does not necessarily have a mood disorder. They are being worn down by the relentless cognitive and emotional weight of a condition that never, ever takes a day off. Treating distress as depression is not just ineffective, it is invalidating in a way that can make things significantly worse. Our friends living with type 1 diabetes don't need an additional diagnosis. They need to be seen, heard, and cared for. I want to spend real time here because I don't think most people, including most clinicians outside of endocrinologists, truly grasp what type 1 diabetes management requires on a minute-to-minute basis. A person living with type 1 is making clinical decisions all day long. What did I eat? How many carbs? What is my blood sugar right now? And what will it be in 2 hours? Am I about to exercise because that changes everything? Am I stressed because cortisol raises it? Did I sleep poorly because that raises my blood sugar too? Is this infusion site working? Is this insulin degraded from the heat? Do I feel low or am I just tired? Is this headache a low or dehydration or something else entirely? Research published in 2026 in Diabetic Medicine found that participants identified the mental load of diabetes management as a major feature of diabetes distress, describing the constant monitoring and overwhelming nature of living with type 1 diabetes. One participant described it in this way. Diabetes has its own region in your brain. It's like it took over a whole part of your brain and you can never turn it off. Never turn it off. At 2 a.m. when an alarm goes off. At a dinner party when someone asks you why you keep checking your phone. At a job interview when your CGM vibrates. When you are giving a presentation and you feel the sweat coming and you can't tell if it's nerves or a low. when you go into a test with a high blood sugar because that's better than dropping in the middle of the test. Decision-making about insulin dosing, meal planning, physical activity, and medication adherence is complex and requires constant cognitive effort throughout the day. This is not metaphorical, this is neurological. This is measurable cognitive load being deployed every single hour of every single day in a person's life. This is exactly what my QI project pointed to. When we gave patients CGM, when we replaced the guessing with real-time data, the distress came down, I think. Not because their diabetes got easier, but because they had information, because the uncertainty, which is its own particular cruelty, was reduced. The tool didn't fix the disease, it gave people back a little bit of control over their own story. Now I want to talk about the well-meaning things that people say to someone with type 1 diabetes that land like a punch. My cousin cured their diabetes with diet. No, type 1 diabetes is an autoimmune condition. The pancreatic beta cells have been destroyed by the body's own immune system. There is no dietary intervention that reverses that. This conflation with type 2 diabetes is not just inaccurate, it implies that the person with type 1 diabetes could fix themselves if they just tried harder. That is a harmful thing to say. Your cousin may have been misdiagnosed. You can eat that? I thought diabetics couldn't eat sugar. False. People with type 1 diabetes can eat whatever they choose. They dose insulin accordingly. What they cannot do is stop being diabetic regardless of what they eat. At least it's manageable now with all the technology. Technology has been genuinely transformative. I celebrate it, I prescribe it. My own QI data showed it reduces distress. And technology also means more alerts, more device failures, more insurance battles, more time on hold with a prior authorization department fighting for a CGM that the evidence clearly supports. And then there's this one, and I say this with care because it comes from a place of genuine hope. I heard they're so close to a cure. The science is extraordinary. We are making real progress, and I do not want to diminish that. But the focus on a future cure can inadvertently communicate that the present suffering is temporary and therefore less urgent. That people living with type 1 today are just in a waiting room. There are over 2 million Americans living with type 1 diabetes right now. They are not in a waiting room. They are living full, complicated, demanding lives, and they deserve support for the experience they are having today, not just hope for a future that has not been shown to be certain. We can hold both. We can look for a cure, and we can care deeply about the people living with this disease right now. We need to fund the people living with type 1 diabetes today, day in and day out, as a priority as much as we fund a cure. We have to start seeing these people living with type 1 diabetes now. We have been discussing a cure for type 1 diabetes since the 1920s, literally over a century. And in the meantime, we have forgotten about the people living with type 1 right now. We are not doing enough for them. They don't have access to care and support that they need. For the clinicians listening, we have to screen for diabetes distress systematically. The problem areas in diabetes scale, also known as PAID, takes 5 minutes. The diabetes distress scale takes 5 minutes. These validated tools exist. They need to become as routine as checking an A1C. We also need to stop conflating a rising A1C with a non-compliant patient. When I see a worsening A1C in a patient with type 1 diabetes, my first question is not about their diet or their medication adherence. It is, what is the emotional weight of this disease for you right now? Because higher levels of diabetes distress are associated with increased depression scores and worse glycemic outcomes. The distress comes first. The A1C follows. We are treating the downstream number when we should be addressing the upstream experience. A1C is no longer a good tool for assessing type 1 diabetes control. Time in range is much more relevant today anyway. And the tools matter. My fellowship data showed that access to CGM moved the needle on distress scores. That means fighting for access, doing the prior auth, appealing the denial, making the case to the insurance company. This is not administrative work. It is clinical care. It is mental health care. It is advocacy with a direct measurable impact on patient well-being. When someone with type 1 tells you they are burned out, believe them. Don't push harder. Don't add another medication. Add your time first. If you don't have it, find someone with expertise and more time. Direct care endocrinologists can be hugely helpful here. Make the team bigger and more accessible. Refer to a diabetes care and education specialist if a direct care endocrinologist is not accessible. Refer to a therapist with chronic illness experience. Better if they have experience with type 1 diabetes. Sit with the person in what they are carrying. Validate, acknowledge the work they're putting in. Be a teammate and recognize they are doing more work than you ever could do for them. If you love someone with type 1 diabetes, here is what I want you to take from this episode. Ask them how they are doing with it, not how their numbers are, not what their last A1C was. How are they doing with the weight of it? And then just listen. Don't offer cures, don't minimize, don't pivot to the breakthrough on the horizon. Be present with them in the reality they are living right now. And if you are a person living with type 1 and you feel this bone-deep exhaustion that is so hard to explain to people who don't live it, it has a name. It is real. It is documented in the research. It is not weakness or failure. It is the rational response to an irrational amount of daily demand placed on a human being. I have been thinking about this since my fellowship. I have sat with my findings and my patients for a decade. And what I know is this. If you have type 1 diabetes, you deserve care that sees the whole of you, not just your glucose curve. I'm Dr. Arti Thangudu. Thank you for being here. Share this episode with someone who loves a person with type 1 diabetes. It might be the most important thing they hear this week. And I'll see you on the next episode of Endocrine Matters.